Hello and welcome to episode 22 of EMSNation. My name is Faizan Arshad. Hey folks, today we have a very exciting episode done by some very good friends of mine on the left coast, the west coast, UCSD, University of California, San Diego, EMS Division, led by their current fellow who is Joelle Donofio. And she is very interesting indeed. She did a residency in pediatrics, pursued a fellowship in pediatric emergency medicine, and is currently the second such fellow in the country pursuing an EMS fellowship. So as we become more sensitive to our limitations in pre-hospital care, certainly we realize that pediatrics, and especially critical care pediatrics, represents a remarkable opportunity for us to improve on a global scale, both from assessment to management of our critically ill pediatric patients. These can oftentimes represent sphincter tightening moments for providers who do not encounter sick kids that often. Now, the topic of conversation today is the challenge, the ethics, the system-wide issues in regards to pre-hospital pediatric intubation and RSI, rapid sequence intubation. And it's fitting that Dr. Donofrio, along with the entire EMS division at UCSD, focused on the advanced airway and endotracheal intubation. This episode is on pediatrics with some amazing articles which are all referenced in the show notes, and we certainly encourage you all to take a look at them both before if you're able to, but certainly after, so you can have a good estimation of the primary literature. But as we all know, UCSD is famous for the paramedic RSI trials, which ultimately ended up showing that in the mid-90s that while pre-hospital RSI and intubation is possible, we certainly have to be cautious given that it is a low and limited resource environment. Unbeknownst hypoxia as well as bradycardia need to be observed for. So those were some monumental trials which are certainly paramount in EMS literature. So hang on guys, this is a great episode with a cast of characters from UCSD whom I consider very close friends. So stay tuned and enjoy.
Alright, so this is Joelle Donofio, and we are doing a EMS University of California San Diego Journal Club, and we're going to be publishing this on EMSNation with Dr. Faizan. And so I'll just go around the table and everyone introduce who you are, and then we'll talk about the literature. We'll start with Matt.
Matt Goebel, second year medical student at UC San Diego School of Medicine.
Chris Kahn, I'm the Fellowship Program Director here at UC San Diego.
John Serra, Medical Director of Rural Metro, Southern California, and Chula Vista.
Jake Jacoby, Department of Emergency Medicine, UC San Diego.
Jim Dunford, City of San Diego EMS Medical Director.
Aaron Herbleth, third year resident at UCSD Emergency Medicine.
Gary Vilk, UCSD Department of Emergency Medicine, Carlsbad, Medical Director for the Fire Department.
Yeah, let's do a little bit closer. It's a good way to test you guys, huh? All right, so I thought I'd be absolutely terrible to you guys and start out with a paper that I emailed out at 7 o'clock in the morning because it was brought to my attention actually last night while I was on an ED shift at Chris Coyne. And it's called Pediatric Intubation by Paramedics in a Large Emergency Medical Services System, Process, Challenges, and Outcomes. And it's by Dr. Precker et al. From Washington. And I thought this was one of the best written papers and analyses in peds pre-hospital intubation since Mary Ann studies, to be honest. It's really impressive. It's retrospective, so it's not a random, like an RCT, but they looked at all of their intubations in kids under the age of 13 from 2006 to 2012. They had 299 cases during the 6.3 years with an incidence of 1 intubation per almost 2,200 EMS responses. Less than half of them were for cardiac arrest. 2/3 were intubated on the first attempt. And this is interesting. They talk about an overall success for 97%. But I'm going to talk about why that's actually not a really valid number. And then what they took from this paper that was new and innovative is they were looking at the documentation on what corrective skills the paramedics did with each failed intubation to look at success. That way we can look at, well, if you are going to be doing pre-hospital pediatric intubation, what things are going to be helpful and what should you be teaching your medics. And so their corrective actions that were most common were 33% changing equipment, 32% suctioning, which I'm sure all of you guys have intubated a kid, and they have very small mouths. They're often filled with saliva, and they vomit very, very easily. As anyone who has a child knows or works in PCD, kids vomit a lot to almost anything. If you look at them wrong, they will vomit. And repositioning the patient, which is always helpful. They had 2%, which was 6 patients of peri-intubation cardiac arrest and 1 iatrogenic tracheal injury. 86% of the ones that made it to the hospital were admitted to the ICU, and the mortality rate was 27% of the patients that actually made it to the ER. So, kind of just for the sake of time, and because there's quite a few papers I wanted to review, some of the things I found particularly interesting about this study is when you look at the details. So that was the abstract. And so you look at it and you're like, that's fantastic. 97% overall intubation success rate. That's incredible. That's pretty good. I mean, it's such a rare encounter, and if you can intubate them overall, it's really nice. But with the devil's really kind of in the details. So let me survey you guys first. How many calls do you guys get where they declare pediatric patients dead in the field?
Almost none.
Just about 0.
Yeah, I have to say I have had many patients who are actually dead brought into the ED. Like, paramedics don't usually like to call kids. So what was interesting to me is they had 76 patients who died on scene and weren't transported to the hospital. And I think for a pediatric population, that's really, really unusual. 76 of the 299 encounters for intubation were declared in the field. And then going down to one of the other things that they talked about is that let me check the numbers. There were 50 patients that were, they were not able to tell the final tube placement. And those were the cases that were resuscitation was terminated in the field. And I think 44 of them was that it wasn't declared on the autopsy, and the others were that the autopsy was missing. So if you have 299 intubations and 50 of your cases you don't know where the tube actually was, can you really say that you have a 97% accuracy? It really actually changes, and I'm so sorry, my notes function are not working right now. I wrote notes on all this. But so your odds of success for intubation go a lot further down. And then one of the things, my pet peeve, because we hear about it all the time, I know I brought it up in front of our pre-hospital committee, is that we often see right main stem intubations. Kids are really short, their airways are really short, the tubes are small, it's really easy to displace the tube. And so this is one of the one of the 2 papers I was reading that talked about right main stem intubation. And they had a pretty high proportion. And for the less than 1-year-old, there was a 14% right main stem intubation. And for the 1 to 5-year-olds, it was 20.7%. That's pretty high. Mm-hmm. So I know that they talked about the complications more of looking at esophageal intubations and a turfed trachea, but I consider right main stem a pretty big complication because the kids can beat that and go hypotensive very quickly, which can lead to bad outcomes. They also had a much higher rate of aspiration pneumonia than you would expect, with 46 out of the 299 having aspiration pneumonia. And as you can guess, if you're diagnosing aspiration pneumonia, I'm figuring those are patients that made it to the ER and weren't part of the 76 that were declared in the field.
Yeah.
And they had an overall complication rate 15.7% with one or more complications occurring out of the 299. So my take on this, there's been a lot of talk on this on Twitter because of that whole, in the abstract, it talks about the 97% success rate. It seems like there's a pretty big risk. It's a very low frequency event. It seems like this group of King County, Washington, has 2 medics that are doing the intubations. They're highly trained. They have at least 6 pediatric intubations. They go back and they do lots of skills. They talked a lot about how they are training these paramedics. It's very interactive, very high level medics. And these are to me, I find these pretty bad outcomes. But I'm biased. I'm a pediatric ER doctor. I'm very, very biased. I want to get your guys' input.
Well, I agree that these are very highly trained medics. Certainly King County has a reputation for having a very strong EMS system. And when we discussed something similar to this article at the NAEMSP meeting just a few days ago, there was a discussion of getting training in the operating room, having minimum number of intubations per year, or you go back to the operating room for further intubations. And it's a training environment that I think a lot of us would love to have. And despite that, what we find is that first pass intubation rates are maybe in the 60 to 70% range, and really it's such a rare skill that's performed that it's difficult to make sure that you're really getting it right and getting it right every time. So I've got to admit that as much as I love intubating, and as much as I have difficulty answering the question of, hey doc, if we can't intubate in the field, why are you doing it as soon as we get to the ER, that I'm not convinced that this is something that is benefiting kids in the field.
I would have to echo a lot of what Dr. Khan is saying as well too, and we have to remember since Dr. Gaucher-Hill's landmark study came out around 2000, this study was done from 2006 to 2012. Not to mention that this study also used RSI, which is not used in majority of systems, which may suggest that we have to look at this experience as something that may not be able to be replicated in other systems as well too. So I'm interested in how this was implemented in a post Marion Gaucher environment, where a lot of systems left the use of endotracheal intubation in favor of the fact that the outcomes of patients that were able to be bag valve masked were the same, if not superior, to the patients in mortality compared to those that were endotracheally intubated. So I have to consider this paper in that environment and whether or not it's something that's generalizable to other systems that are out there right now. As Dr. Khan was saying, King County has a pretty strong reputation for being a very advanced EMS system. They certainly limit the number of paramedics that are in their system so they can maintain a very strong experience for the individuals, which is not necessarily the same as other either urban or suburban environments.
And I'm really glad you brought up the rock. I just wanted to interrupt real quick, and also one of the things I forgot in my Speedos going through this paper is they talked about there were 8 cases that made it to the ED, and 2 of those didn't have to get intubated. Like, it was 8 failed intubations, and 2 didn't get intubated. They woke up enough. And then when you go through and you look at why were kids intubated, there was actually a significant proportion of status patients. I think there were 31 kids in the under 1 year of age that got intubated for status. And I know personally in the ED, I don't intubate a lot of status patients. I'll bag them for a good 15 minutes and really try to wake them up, because those are if you don't have to intubate them, they can just wake up. It's so much easier.
Mm-hmm. Yeah, I'll have to study this paper a little bit more to really be completely aware of all of it means. I mean, I think it's always 2 sides of the coin, success is always defined by the tube finally got put in the right place. And the question that we have come to recognize over the years is that, that may not be, that it could be a Pyrrhic victory is really it, right? You can put a tube in, but if it takes a long time to get it in and you are encountering these peri-procedural complications, particularly in very viable people, including these bradycardic events that required interventions and you require, and even a couple percent incidence of peri-procedural arrest, those are potentially very viable people that suddenly you have to take very significantly when you're comparing intubating kids who probably, there was a population of these kids who probably were flaccid dead to begin with, which should be a very easy intubation. So, hats off to the folks that can do this. I think everybody understands experience you get better at it. I think these guys should be as good as anybody possibly could be at it, but it's not without its risk. And, the best would be is if we could have some kind of a randomized study that says whether BVM versus this resulted in any change in outcome. I mean, that's the ultimate question. It's not whether you got a tube in or not. A tube doesn't really necessarily save anybody's life. This is a procedural study that showed that they can put it in with some complications, but in terms of whether or not it benefited the patient, I think that still gets back to the Gaucher paper, is are we really improving people's lives, which should be the gold standard ultimately. So, our experience with RSI procedures in San Diego County years ago was you can put in a tube successfully, but you can also be expected that significant physiologic derangement might occur. Even things like hyperventilation, which I'm not sure was it recorded after post-intubation and first arrival at the hospital, whether or not the patients were being ventilated within a controlled range that you would like to see kids, or because we know that that's actually another predictor in head injured patients of bad outcomes. And it's very likely that people who get intubated in the field will be hyperventilated unless their quantitative end-tidal CO2s are carefully monitored. And I noticed that a significant number of these didn't use quantitative capnometry. It was sort of a positive-negative study, which could, in the excitement of intubating a child, it's not that unusual to overbreathe them. And there's neurologic issues related to head injuries as well as obvious issues of increasing intrathoracic pressure and decreasing, return to the heart in shock patients from doing that too. So bottom line is, if anybody can probably do this safely, it's Seattle, and I think this probably defines what the best we're going to expect out of an optimal system.
Are you okay with those results?
Well, like I say, I think we still allow intubation in San Diego. We don't have even the data that these guys have now shown to be able to prove it. Would I accept this? I would go back and I'd be more attentive than ever to the pre-oxygenation parameters preceding intubation to find out what it was about these certain cases and whether, in spite of optimal management, they were going to have these complications. We'll never get this all right. Nobody could ever get everything right. In the emergency department, we experience some of these same side effects. We guard against them. The question is whether the pre-hospital environment has some inherent property that precludes us from getting any better than this. I really don't know the answer.
The other population you brought up was the out-of-hospital mortality rates. Right? And because those, if they're, dead kids tend to be the easiest ones to intubate versus, movement ones or the status ones. The question is, the other tubes getting in there are not getting other complications that we're missing because.
And it doesn't talk about were the ones that died, were these SIDS babies that should have actually maybe been left at home for forensics and different things, or were they actually alive, viable with a pulse?
And a complication of the airway.
Exactly.
Did not help them, or his bag last might have. It's hard to say. It's all speculation.
It'd be nice to have some, even a Glasgow score or something that could correlate with the likelihood of success, because I think other studies have shown that. Like Gary was saying, if you've got a gag, it's obviously a lot easier. You're going to have to use a paralytic if you're going to hope to get successful intubation. And so we don't really know exactly the baseline of the majority of the kids in terms of whether they were flaccid or were actually combative or seizing, etc.
Because half got our side.
Yeah.
It's interesting.
Mm-hmm.
And then 50 of them end up in the ward. So it doesn't leave you a whole lot in there that were sort of low GCS that you could actually do without RSI.
Yeah.
There's a lot of data here, and that's the challenge of trying to interpret it.
There's a lot of I'm really impressed with this data bank. I think they did a great job.
So one of the takeaways that you can look at from the study here was the point that almost 20%, I think it was 19% of the children who were intubated had mainstem bronchus intubation as a complication. Now, it would seem as though this might, since one out of 5 is having that complication, it might be reasonable to create some sort of objective way to determine right mainstem intubations, either using some other device as yet to be invented, but something that can actually look at differential volumes in the lung, either through ultrasound or some other mechanical device. And it would seem as though this might be an adjunct that could be worked on in the future.
We looked at this because we had right mainstem intubation issues so much, like in our hospitals, and we realized this is a big error. So we found that there's really no recommended ET tube depth by the AHA or AEP or PALS. And there's 24 different equations for how deep should the tube go, and we all use a different equation. Our children's hospital, our air, and our ground all use different ones. And so having a standardized and then having on your, we have fantastic color-coded pediatric dosing cards that have, in addition to the medication, mLs, not just milligrams. It tells you the ET tube size, and having the depth on there, I think, would be really helpful. If you're going to be intubating, just automatically have it on the card, this is your tube size, and this is how deep you go. Mm-hmm. That way it gives them that automatic awareness of, please don't hub it. Mm-hmm. It's easy. Their airways are so small. Even as an experienced, PCR doctor, it's one of those things you have to be very conscious of how deep are you going. And we usually end up right-mainstemming on accidentally pulling back as you listen to bilateral breath sounds until you get that optimal bilateral sound.
Yeah. Correct. So that, which can be done more easily in the emergency department, is very difficult in the field, particularly with parents and all the sounds of the street and the houses. And so having some objective way to monitor that might be a wonderful adjunct.
Even the transfers are moving the big bag a little too. Things move, so you never knew what it was originally.
You have a half a centimeter of error between extubation and right mainstem in some of these kids, and moving onto a CT scanner, you can extubate a kid. Mm-hmm. It's tough.
Have you guys considered the use of lung ultrasound for that? Because if you right mainstem, then you wouldn't get sliding sign on the left side. And that would be a very quick, objective test to do. I mean, pre-hospital, the technology isn't cheap enough yet to have one on every rig, but certainly in the ED, that's something you could be doing.
There's multiple ways of looking to see where your tube is using ultrasound, and it's something that ER and emergency physicians are becoming more comfortable with as part of their peri-code or coding situations with their patients, which includes pediatrics and adults, whether or not it's changing your opinion of whether or not something is volume overload or if it's pneumothorax. It certainly has been something that people are becoming more and more comfortable with as an adjunct that's faster and more sensitive than traditional radiography. So it's something that I think that is going to become more popular. Seeing the number of times that ultrasound has been available in a pre-hospital situation is becoming more and more part of a future algorithm that I think we will see in the future. It's, as you've mentioned correctly, Matt, it's just a question of the price point and the durability of the device. If you look at the cardiac monitors that are available out there and you look at just 15 to 20 years ago, the price point has dropped enough that it's feasible for even volunteer services to have this equipment. We can predict another 5 to 10 years down the road that ultrasound may be durable enough and cost affordable enough that we can actually consider putting this as part of a pre-hospital algorithm. It also can be used something that you're using during intubation to see that if you're in the trachea, if you're in the esophagus. So it adds an extra measure of reassessment of your patient to make sure that you are in the correct location. But as Dr. Dunford mentioned, one of the things that we'd like to see even more that is available currently is end-tidal CO2 as one of our markers. Certainly not going to help you necessarily too much when you're looking at right mainstem intubation, but is helpful in a lot of other measures for oxygenation.
Dr. Donofrio, sum this up for us. What is your indication when intubation is mandated? as opposed to BVM? Is there a clinical indication when intubation provides the only alternative to a child dying? I mean, or do you feel that in almost all cases you can bag a patient without?
This is going to sound really, really humbling and terrible.
Mm-hmm.
It took me about 5 years. I think it was because I did 6 years of pediatric ICU as a resident, and I think it was my second month during my peds year fellowship where I really, truly learned to respect to bag a patient. And that there was no, like, as in a controlled environment, there was really nothing. I mean, a foreign body that was obstructing the airway is one thing. Like, you can't, obviously, you're not going to be able to bag through that, and that can cause a lot of problems. Mm-hmm. But anything else, learning the skill of how to truly bag a patient well and get a good seal, we could bag almost every single patient. And you can bag until help comes, until you have the right setup, until you have the things that you need. And we will sit and bag for a good 5 to 30 minutes until we have everything we need, until everyone in the room is ready to position. The patient is positioned, and you have everything you need to have because your first attempt is going to be the best odds of success. So we set up the patient to have the best odds of success in the first intubation, and we'll bag almost everything.
Yeah.
We don't do rapid sequence intubation. We'll do a delayed sequence to get optimization. Mm-hmm. So that's where I'm like I feel kind of, it's going to sound really odd as well, but I feel bad for the medics. This is a really stressful situation that they're put into, and looking at these odds that they have in this paper, 299 cases, 76 deaths, like 20% risk of right main stem. There's a tracheal perforation. It seems like there's a lot of risks, and there's a lot more emotion tied to the pediatric arrest than to a lot of the adult arrests. And I wonder if you went back and you looked at more of the psychological components of the stress that you're putting on the medics. Hindsight being 2020, would they have wanted to be put in this situation if they knew that BVM was going to give them the same or better results?
Primum non nocere.
Exactly.
Do no harm.
And are we harming the medics by putting them in this scenario? Is this psychologically harming? Mm-hmm. Okay, so to summarize real quick, because I know we have to go to our other conferences. The next paper is by Dr. Bigelow et al. This is in pre-hospital emergency care in 2015, and this is Intubation in Pediatric Neonatal Critical Care Transport National Performance. And I included this because as we look at pre-hospital intubation, in my mind, there is your rural medics, your urban medics, your helicopter EMS with your critical care paramedics, and then you have your pediatric transports. And so I included journals that looked at the rates of all of them. That way we can actually compare them head to head and see how does everyone do, and are they looking at a different population. So this is looking specifically at your pediatric and neonatal transports and those intubations. And this was, let's see, there were 9 participating centers over a 6-month period from January to June of 2013. They invited 14 but got 9 back. And they were looking at, let's see, let's scroll down, the abstract doesn't have quite as many. They had 4,600 pediatric transports, about 2,600 NICU transports during 6 months, so quite a bit of pediatrics, quite a bit of neonatal. And then when they're looking at the first intubation success attempt, for neonatal transport, it was similar to pediatric, which is still lower than you would expect. It was 60% versus 67% first pass success. So even in pediatric trained people, first attempt success is pretty low for little kids. And what they went through a little bit more on the paper is they talked about for a NICU peds transport team, they more frequently intubate NICU patients rather than the pediatric patients. So when you're doing your training of people who are going to be participating in your transport team, you need to ensure that they know how to do NICU intubations. that's a very, very critical proportion, and that's the majority of the intubations they're going to do. And that is an entirely different skill set, different medications, different tube sizes. And then the other thing that they stressed, which I absolutely love, is they looked at what is the educational component of all these providers, and they compared how many educational programs do you have to what is your success rate, and they found, not shockingly whatsoever, the more educational programs you have, so they have, I think it was Transport G, had the highest overall first attempt success rate of 87%, and they had 5 educational programs, that's like 5 different methods of instruction to keep their providers up to date with pediatric intubation, compared to program H, which had a first rate attempt success of 35%. And they had one method, and they did not mandate live OR intubations of pediatrics. And then they have, if you have the paper open, they have this really great figure 1, where they compare the success rates to the institute. So you can actually see the huge difference between G and H graphically, the 87% versus 35%. And then when you go down, if you look at table 3, they start going into what are the types of intubation instructions and what are the different things they're doing and how many successful intubation attempts do you need to have. You can see the huge difference that the more requirements you have, the better they do. So, in summary, if you have a pediatric NICU transport team, they're going to be intubating. They're usually the team that goes to the outside hospital to intubate and take care of these really critical kids, especially the NICU. You gosh darn should have a really good educational program and several different methods to instruct and keep up your CE for that. And their suggestion, based on this paper, is that we should come up with a national benchmark performance to ensure that all the different programs that are doing this high-risk procedure, and like the pediatric NICU transport, there should be minimums of what they can actually do. So there's not such a huge program variance from 38% to 87%. So I like that. I like the idea of starting to look at data to establish national benchmarks.
Well, Dr. Donofrio, one of the things that I think that is important is considering our baseline ability to perform an intubation, whether it's an adult or a child in this case. When paramedics are graduating from their program, how many intubations they need, and what is the similarity between live and artificial. And as simulated intubations have become more realistic with the ability to cause laryngospasm, putting fluids in the airways, secretions in the airways, getting a little bit more realistic. From the data that I'm familiar with, it's approximately 25% of your intubation skills can be obtained from simulation, whereas 75% still needs to be a live situation. It doesn't necessarily discriminate between OR intubations versus field intubations, but honestly, the most important thing we would all like to believe is that the field intubations and the previous experience with that is important. As you can also point out on here, is that the minimum number of intubations to maintain competency is a very hot topic. For example, in San Diego County alone, we have approximately 1,000 paramedics, and the total number of intubations is less than 1,000, which would say that on average, without even considering a bell curve, is your average paramedic is getting less than 1 intubation a year. And considering the fact that they only need 5 intubations to graduate from paramedic school, do they actually have the muscle memory or the innate skills in order to continue such a low frequency intubation? And then to add on top of that is that there's very few pediatric intubations. Of all these intubations that they're doing, which is already less than 1, how low do we get in percentages before we say that how many pediatric intubations do you need a year to have that? If most of us would agree that that number should be at least 1, then we can already say in this county alone is we don't have enough intubations to be able to do that. What we've accepted as an alternative is, with the primum non nocere, is we only have a 30-second look as all the paramedics are allowed to have. After that, they have to continue to bag this patient. And more importantly, if they are unable to obtain the airway if they're unable to get a view that they're looking for, they're not allowed to attempt to pass the view, pass it. So one of the things in this is, what is the initial experience they need to have, and what is the ongoing experience they need to have? And even though, as you mentioned, Institution G has 5 ways of training them, do we really care about simulation, classroom, PowerPoint, video recorded sessions, or online modules, or does it really need to be the live? In this study, they are suggesting that if you replace it with any one of those 5 sessions, that you might have better outcomes. Or is it just a higher expectation that G has over H? Is this a marker of a more mature QA/QI program that's involved?
Ooh, I like that.
Hey friends, I'm going to take a brief moment to pause the show and bring you a word from our sponsors. No, not the sponsors you may traditionally think of, but rather sponsors that are aimed to help eliminate healthcare disparities. This is a very special project I'd like to announce during EMS week for folks to trial. It comes at absolutely no cost and is ultimately designed to optimize your training experience and help translate into improved outcomes within your community in relation to out-of-hospital cardiac arrest. Recently, a group of colleagues of mine and I had the pleasure of coming together and reviewing the science and literature on feedback in CPR, and the data pretty much speaks for itself. Dr. Bobrow, the state EMS medical director of Arizona, has done tremendous work on this, and we now know that all the major defibrillator companies come with some sort of active CPR feedback. Nevertheless, we are acutely aware that once you know a single EMS system, you know a single EMS system, and budgetary constraints are real-world problems and challenges. Not everyone can afford the defibrillator component to their device. So what have we done is designed a watch app for the Apple Watch called Perfect CPR. Now, we should be very important to state this is designed for training purposes only, but nevertheless, once a provider opens up the app using the accelerometer and gyrometer built into the Apple Watch, you will be able to get direct feedback on your rate, depth of compression, as well as recoil. So please check this app out. It is available at $0 in the Apple Watch iTunes Store, and it's called Perfect CPR. Please also find us and follow us on Twitter at Perfect CPR. Again, we're beta testing for this, very excited to launch during EMS week at a cost of $0 and would love your feedback. We can all do a part to help improve the health disparities within our country, and feedback is definitely a requisite component to that. Check us out.
What's interesting too, it shows that you don't need to worry about as much the numbers of initial attempts you have. 1 to 5 attempts or intubations prior to becoming a crew member, basically being allowed to intubate. The group that had the most attempts didn't necessarily have the most first success rates, and it seems to be more the ongoing training, obviously, that has an impact than how many you've had whatever distance in the past. I found that interesting. And also, the one group that had the most challenges happened to be the one that had 90+% fixed wing transports. 71 to 80% were fixed wings, which is an interesting group there, right? Is it just a lack of other experience because they only get a couple a year, and so the rates are really low versus the ones that do transports on a daily basis may have higher percentage. So maybe a function of their frequency as well as their education, the ongoing education.
That's true.
Additionally, too, is the type of provider that's involved in each one of these is variable. Between respiratory therapists, paramedics, and RNs, there's no physicians in the group, and I'm not suggesting that physicians would make any difference at all. But we don't necessarily have a method in which saying that respiratory therapists are superior to paramedics, are superior to RNs. So to consider which one of those is perhaps the most skilled in order to perform that is important to know. And additionally, in this paper, all we know is first in line to intubate. We don't know who is actually the ones that have the highest success rates out of each one of these institutions. So there could be some significant information in there as well too that I'd be interested in finding more out of.
All right, do you guys want to move to the UK paper or to the US HEMS paper next?
UK paper.
Okay. So this paper is by Dr. Nevin et al., and this was published in Resuscitation in 2014. This is an observational study of pediatric prehospital intubation and anesthesia in 1,933 children attended by a physician-led prehospital trauma service. And thank you, Dr. Nevin, for emailing this over to me. So this has been, I really like this paper because I think it's really interesting looking at what do they do abroad versus what do we do in the States. Is there a huge difference in outcomes when you look at a physician-run pre-hospital system versus our medic-run system? So this was a 12-year retrospective database analysis of pediatric patients attended by the UK physician-led pre-hospital trauma service. They included patients less than 16 years of age that got advanced airway intervention. And they saw between January 2000 to October 2011, roughly 1,900 kids. There were 315 intubations, which is about 16%. 81% did receive a rapid sequence intubation, and 19% were intubated without anesthesia in the setting of a near or actual cardiac arrest. There were only 3 kids under the age of a year, which makes this more of an interesting database. And the intubation success rate was 99.7% with a single failed intubation during the study period. And their conclusion in the abstract is that PEDS pre-hospital intubation is not infrequent in a high-volume trauma service. So going through it a little bit more in depth, what I really liked about their methods is that they have an SOP that has you get 2 attempts, and after the drug administration, and if you fail after the 2 attempts, then you go ahead and place a supraglottic device. They either used, I think they have the combi tube or the LMA, and if those fail, then a surgical airway. And the third alternative is that you can just bag the patient while transporting to hospital if you fail doing an intubation. So looking at the results, they had, of the patients who were intubated, they had the one failed, and I thought there was another, just kidding. Sorry. Good, a lot of papers. Their demographics were different than most of the other demographics we see, where they have a majority of older kids. So they had 3 kids under the age of 1. 25%, which is 78 patients, were 1 to 5 years old. 77, which is 24%, were 6 to 10 years old, and 157, which is about 50%, were 11 to 15 years old. So I think when you talk about pediatric airway, really it's that less than 12, maybe really more than less than 8, and getting into a more difficult airway in the toddler and infant years. So a majority of their intubations were in older age subset with the 11 to 15-year-old.
Yeah, that's definitely pointed out here on figure 2, where you can just visually take a look there and see that the majority of these intubations were happening in big kids that people who are more adult trained probably wouldn't feel nearly as uncomfortable with.
Mm-hmm. I think a really interesting part of their papers also, they looked at the frequency by time of day, because then, when do you need to staff it? Is this like going out Friday and Saturday night, this toddler's getting intoxicated and needing to get intubated after their driving accidents? And they showed pretty concisely, really from during the school period hours, and especially when school lets out and all the kids are kind of, going back home and mobilizing, those are the periods where, not shockingly, you have the PEDS versus auto kind of types of accidents, where a majority of their traumas were actually pedestrian and falling out of heights, which I think we see in the U.S. very commonly as kids falling out of windows. And those are periods where kids tend to be awake and out and playing. So if you're going to try to staff accordingly for pediatric intubations, knowing your periods, keys, utility would be helpful. Their scene time was about 20 minutes if they did not receive intubation. When there was intubation, it was about 40 minutes. So intubating does increase your on-scene time, although the UK is a little bit different than the US, and their pre-hospital trauma management with the physician-led teams, they give a lot more medications, blood products. I think they give TXA. Like, they do a lot of stuff to their trauma patients. So that 20-minute delay may not actually be a delay of care that they'd be receiving in the ED. And that would be something I can't really specifically speak on, but it is a difference from our systems to their systems. Let's see.
I think just staying where Dr. Khan had mentioned on the, when we're comparing, our goal today is to compare a lot of articles, and a lot of times, again, I've mentioned a couple times before, is for right or for wrong reasons, Marianne Gaucher's Hill's article from 2000 was one of the bars that we had set as to compare articles together. And if you look at a lot of the studies that are out there, is they specifically use age 12 and under in order to evaluate that. In this study, as Dr. Khan pointed out, ages 13, 14, and 15 combined equal 1/3 of the entire data set. And I know a lot of our medics would be very comfortable in that range. There's still a lot of anxiety and angst in general for any airway, but really when we're talking about pediatric airways, there's a reason why we've selected the preteen population as kind of a cutoff. So to compare this study to others, knowing that 1/3 of the patients are in there, I'd really like to see the way the data set worked out. I don't know if it's just coincidence, but the patient that was not able to be intubated was a 3-year-old in this study, which is more fitting with what we're seeing here too. The other thing that I consider in this study too is that not every system has the backup of being able to perform an emergency airway if that's there. To have that in your algorithm would certainly, and somebody who was skilled enough to do it, would certainly change my opinion of using RSI if I knew that ultimately down the line the backup was that if you used RSI and you couldn't get the tube in, have you made the situation worse by now not being able to bag on top of that, which is some of what we have found in other data sets that have been part of the reason why we don't necessarily use RSI, especially in ground transport. So that's something that I'd like to consider in this study as well too, before I make any strong opinions as to how this is generalizable to any other system, never mind just a physician-led system.
I think what I really liked also about the pathway, you get 2 attempts and then you get a supraglottic device. The 2016 paper we had talked about earlier, 54 patients of the 299 had 3 or more attempts done. So I think that having a very clear, this is what you do, this is your next step, and having a very, very defined backup plan, just like you're saying, is very key.
I apologize for changing the subject slightly, but for a moment I've got to put on my NHTSA traffic safety hat. And just taking a look here at Table 2, you'll notice that out of the 191 road traffic crashes, which globally is a leading cause of death, you'll see that 140 were pedestrians. And I just want to point out there's a lot of good literature out there describing both the epidemiology of pedestrian injury and some things we can do to help decrease those numbers. So just want to put that plug in there.
Primary prevention is very important. Big part of our role, I think, is underplayed in the EMS world.
It's interesting, you said that the protocol is 2 intubation attempts and you go to a supraglottic airway, although the supraglottic airway, they said, wasn't introduced until 2/3 of the way through the study. Which implies that you didn't have that backup for 2/3 of the patients. And then their own limitations report that they don't even have the numbers of attempts. It was sort of an implication that you got the tube in place, you followed the protocol, and did 2 or fewer attempts. So,
that's just the assumption.
As a physician, am I not going to give a 3rd attempt in the field when I don't have supraglottic airway or not? Ultimately, it'll be documented as a completed attempt, even though my protocol says I should only do 2 attempts or not. So, it's interesting, and especially if you have 95 doctors doing the 300 procedures, you've got to wonder if it's a retrospective chart, you are limited by that.
It was good to see that there were no surgical airways. And the one failed intubation, they were able to bag and had successful intubation in the hospital.
And no backups were needed because they were all done within 2 attempts.
Theoretically.
Oh, no, they reported it.
They don't record the number of attempts in this. They assumed that if it was a successful airway, it was done in 2 attempts, but there is no documentation of how many attempts were done, and there was no backup system for 2/3 of the study. That's one question. If I, as a field provider, if I was out there doing the helicopter and I had a kid and I'm trying to intubate him, I paralyzed him or whatnot, and I failed my second attempt, am I going to do a third attempt, even though my protocol theoretically says I'm not supposed to? I probably will. I'll probably go and take another look. I had a good look the second time, just couldn't get him for whatever reason, start resetting, bag it back up, and give it a third attempt. In the study, it'll document it as a successful attempt, and based on their protocols, would define it as less than 2 attempts. So
it's true. We never got the first attempt success, so we can't use that as a number.
Correct.
But overall, really good paper, and it's helpful to know. Different population, different mechanism, because it's primarily trauma, but really interesting and does show the success of their trained physician transports. Any other comments on that word? Cool. So moving on to Dr. I'm going to mistake this pronunciation, Tolfsen et al., and this is in Pediatric Emergency Care 2013. 260 pediatric emergency airway encounters by air transport personnel. This is a report of the Air Transport Emergency Airway Management Project. And this is a review of intubation flight records from 89 rotorcraft multi-state from the U.S. Emergency Flight Service from January 2007 to December 2009 in patients under the age of 15. Again, showing that we all have conflicting ages in the papers of what we're looking at considering pediatric airways. They had 260 peds intubations, 88, which was about 34%, were medical, 172 were trauma, which is about 66%, 98.8, which was 257, underwent the orotracheal intubation attempt as the first method. Their first attempt success was 78.6%, and it was ultimately successful in 95.7%. And their medical and their trauma had similar success rates, 98 versus 95%. And they had when they looked at the age groups, there was no difference in intubation success. They did have 3 patients that had an extraglottic device, and there was a CRIC performed twice, which they considered both successful. So they concluded that pre-hospital peds intubation by air transport providers using RSI is highly successful. So again, it's another study that uses RSI. So this was a little bit more detail. This is AirVac, and they do transports for 1,000 hospitals as of this time. They have an average of 26,000 flights per year, which is pretty impressive, both interfacility and on-scene, and most of them are rural. And there's a beautiful map looking at all the different states in the Midwest, kind of the South, Midwest that they cover. And let's see. They have a beautiful graph on figure 2 where they look at their 260 patients. They have the oral tracheal intubation, 257. Of the 11 failed, 7 were LMAs, 2 went to combi tube, and 2 went to a surgical airway. I like that they actually specifically said what supraglottic device they used, and I wish there had been a little bit of commentary on what they thought worked best, because I think there's a huge controversy in the peds airway with the supraglottics right now, just what's better, which one should we be using? Do we have any literature on it? And I know Anders put out a paper recently talking about pediatric supraglottic airways, but there's really not too much data. This is interesting, having 9 of the 257 be supraglottics. So they did have 55 in the 0 to 2 age group with a 96.4% success rate. And I think that was pretty impressive, having such a young age group and still having pretty good success rate. I would have liked to have more data on why they performed the rescue CRIC. So there's one that was a 2-year-old that got a needle CRIC, and there's a 14-year-old that got the open surgical CRIC. Just to get more, I think those are rare cases, and a pediatric pre-hospital CRIC is I would have liked the stories on that, just a little more data. What are your guys' thoughts? Or not?
So overall, I think that the big take-home that I have from this is, after looking at all of these, is we like to think of aeromedical as perhaps one of the areas where there is the most training on procedures. They have a very large resource for, most systems do, have very large resources for training. The first pass attempt here of 82% is probably exceeding that of many, of almost any ground transport system, and probably a lot of emergency physician first pass successes in emergency departments. So I would like to say hats off to that number of 82% or higher. I would like to see, again, as you mentioned, is one of our bars is ages 12 and under. They broke it down into 8 to 14, but still, their success rate, I'd love to see what their first pass was on the 3 to 7 and 0 to 2, because again, those are the ones that routinely pre-hospital caretakers are most concerned about their ability to pass that on. So overall, the number I'd like to point out is first pass success, 82.1% by these aeromedical systems. So hats off to whatever they're doing to get their number into the 80s, which we usually talk 60s and 70s as a number that we're willing to accept as our first pass success.
I will say that, and to their credit, they discussed this in the limitations, that if they were called out to assist with a child and they intubated or attempted to intubate that child, but then the child became unstable, went into cardiac arrest, or for whatever reason was not transported, that's not part of this data set.
That's true.
So there is the possibility that the sicker kids who ended up essentially dying on scene may have had more airway difficulty. And I know that we have seen in some other papers that kids in cardiac arrest tend to have lower first pass and overall intubation success rates than kids who are at least still a bit more alive and fighting for that survival.
It's true, and that's the other limitation of this paper is it's yes or no, success or not. It doesn't talk about all the complications we saw with the paper in 2016, right? Means STEM, like what was the mortality in the hospital? Like, were there other complications, aspiration rates, like different things? That would have been a nice addition, maybe in their next publication.
I think that's sort of my theme on this. All papers that basically measure, quote, successful intubation just mean that the tube finally got in the right spot. Whether it took 1, 2, or 3 times, but they don't really describe, and they sort of say that they talked about whether vital signs were around the intubation were stable or not stable, but no specific values were measured. But I think, even going back to the San Diego RSI trial, the patients didn't do worse because we didn't put the tube in the right place. The patients did worse for some other reason that related to the ability to get it in the first place and how long it took to get it there, and the lack of recognition of other factors beyond that, right? It was a combination of hypoxia and hyperventilation and a whole host of other things. So, the conclusion of our adult RSI trial was not that that they couldn't get it in the right spot. They got it in the right spot. It just was the complications associated with getting it in the right spot. So all studies that talk about successful intubation should really record at what cost did it come to the patient and what benefit was derived. For example,
can you describe, just real quick while you're describing all this, you watch the CPR training. Like you actually, like the in-field CPR intubations you have with the Roxanne, you actually have access of looking at it. Have you seen on the monitor what happens in that peri-intubation phase? And can you describe when you have that prolonged, what you actually see on the monitor, because you've taken a look at this?
You mean in ROC or in the RSI trials?
Yeah, like when you're watching the monitor, or just any of the cardiac arrests with the intubations, and you have a prolonged intubation phase. On the monitor, what do you actually see?
Kind of like what you see in the ER sometimes. If people don't pre-oxygenate, there's a dramatic decline in saturations. And as Danny and we showed, if you start at a sat in the low 90s, you drop right off very quickly. So I think this notion of pre-oxygenation and whether it's feasible to pre-oxygenate individuals, especially kids we know have a much smaller time to desaturation than healthy adults. But on top of that, if you add, lung contusion or some other issue, then the amount of actually the safety zone that you have in pre-oxygenation is much smaller. Again, you take a normal healthy person and you have them take a couple of, really, really deep breaths and wash all that nitrogen out and saturate all their myoglobin with oxygen, not just their hemoglobin, but saturate your body. You can lay there for 5 minutes and never desaturate, right? I mean, that's well known.
I think a child is 2 or 3 minutes.
A child is a couple, 3 minutes, but, whether or not you can actually, if it's even feasible to do that in a car accident upside down, to pre-oxygenate a screaming kid with bleeding and all the other stuff, but what we're getting ourselves into is this risk-benefit curve where it's a lot riskier to do. And so I think that's the thing that has to always be described if you really want to have the most comprehensive paper to me is, what were the potential adverse things and how well did we control for those? Because otherwise, you don't really know about outcome. All you know is tube got in. And tube got in, again, back to the Pyrrhic victory, that can be at a great price. The tube might very well have gotten in as safely in a more controlled setting 10 or 15 minutes later in a hospital with no change in the patient's outcome or maybe even better. So I think that's the question, is not whether you can get it in or not. Almost anybody can get the tube in. It's what did it take to get it in, and how much physiologic derangement did you inflict?
Yeah, it was interesting during a lot of debriefs that were done during the RSI trial, and Jim looked at a lot of this data. The paramedics would say it was an easier, simple intubation in that sense. That the quality of it was a hard, difficult, and they, for the most part, say it was simple. But when you looked at the actual cadence of their RSI attempt, you would start to see dropping off of the oxygenation, the saturations. Then you'd start seeing some bradycardia associated with a number of these cases, and you can measure the time. I mean, this was in the points of over minutes, not just 20 seconds or 30 seconds. But the paramedics were, I think, it's sort of hindsight, we're used to doing a lot of intubations on easy to intubate people, which were typically the cardiac arrest. Right? They're sort of dead, they're easier to get into, and if they were really moving a lot, they never had the opportunity to intubate as much because we didn't have paralytics, we didn't have facilitated intubations. And so when you give them this new skill, and the frequency of using it was less than 1 on average per paramedic per year overall when you looked at it, it's tough to keep a good skill cadence going. That was one of the challenges we saw with the outcomes. Not that you can get the tube in, not that you can't push the meds and paralyze somebody to do it, but the cadence and flow of what's going on during that time period.
Yeah, that was the thing that we found and reported in the annals about 10 years ago, is that it was this striking incidence. It was over 50% of patients had bradycardic hypoxic events associated with intubation that were totally unrecognized by the medics. So every medic immediately reported after they had done the procedure, after giving the RSI, whether it was difficult or easy. They were all described as easy. None of the medics understood what had physiologically been captured by the data that we did. So we were the first system in the world that we put oximetry and capnometry on all patients before RSI. So we knew the oxygenation, and it was almost always very good. Most patients had a SAT above 95%. And then we defined the point of intubation as the moment at which carbon dioxide was first detected in the tube, right? And if you measured and watched what the SATs did, the SATs would drop for maybe 150 seconds or 200 seconds sometimes down into the low 60s, and then finally rise back up after carbon dioxide had been detected. And in many cases with profound bradycardia, down into the 40s or even 30s, and then would finally recover just prior to an arrest when the patient got intubated. And yet the medics thought this was an easy intubation. Yeah, and so that was phase 1 of the study when we recorded a bunch of these patients and published these dramatic desaturations unrecognized. But the more even amazing thing is when we followed those out to what happened on arrival in the ED, it turned out that the hypocapnia was even more closely correlated to bad outcomes than the desaturation. So again, getting the tube in, oh yeah, we got the tube in all right. Then we ventilated the hell out of them all the way to the hospital with a bad head injury, and that actually was bad for them. So again, it's sort of getting the tube in, that's the easy part. It's how did you manage the physiology of this brain-injured person? Did you affect a shock state by hyperventilating somebody and dropping their mean arterial pressure? We don't know, but they were worse if they were hyperventilated. And same thing goes here. So all studies, in my opinion, that talk about success rates of intubation need to be very seriously respectful of the fact that getting the tube in is the easy part. It's whether or not your medics understand and are monitoring the physiology. And for the sake of it, in the operating room and in the emergency department, these same issues have been identified repeatedly, and that's why we're so, more fastidious in the ED today about pre-oxygenation measures and not jumping in and being, panicked about getting an airway. Like you say, you can almost always ventilate somebody and oxygenate somebody. It's rare, but if you've got a foreign body, I guess so. But
my teaching for in the PEDS ED is really emphasizing good BDN and teaching residents how to bag.
Yeah.
And focusing on that a lot, and then the intubation.
There you go.
But with that, we're running out of time. Do you guys have any last closing remarks? Does any of this change your thoughts on pre-hospital intubation of kids specifically?
Pretty much every time I look at any pre-hospital intubation study, whether it be kids, adults, or if there's another category out there, what I discover.
Canine.
Well, maybe that's coming out next year in pre-hospital veterinary emergency care.
Very applicable to you, sir.
The main thing that I discover is that my level of I need to respect this. I need to be mindful of, is this helping the patient? It continues to go up. Honestly, that's not just intubation. That's, for cardiac arrest, should we be transporting that patient? Should we be working them more on scene? Should we be giving adenosine in the field? Or is it that we're trying to convert a lot of sinus tachycardia out there? Almost everything that comes out there is something that makes you go, we need more data on that. And what we really need is for those data to be collected in the setting of good medical direction and a system that is eager to do the QI, QA that's necessary to see if we're actually helping people.
I don't think this is practice changing for me. As all the limitations we've still said is if you're able to oxygenate the patient, what is the indication of the procedure? I'm not sure that I see that in a status epilepticus situation that there's going to need to be anything more than to suctioning, preventing aspiration as much as possible, and waiting out the seizure itself. This is just not practice changing to me, although the data is very interesting and it's something that we need to keep talking about and considering. I don't think I've seen anything that says that we have to do this. Even the 82% first pass success, I think, is going to be less than what I would suspect to be 95% or higher ability to ventilate with a bag valve mask. And if they can cross that number, then I might change my practice.
I think, speaking as a paramedic before starting medical school, I want to sort of go along with what Dr. Serra just said. And innovation at all is a low-frequency, high-risk skill, and especially pediatric, and that adds in particularly high stress to it. With skill degradation and everything, it's hard to stay on top of it, and airway management does not mean getting a piece of plastic in the throat. It means getting oxygen in and CO2 out. So as soon as you're able to ventilate and oxygenate the patient, the emergency is over, regardless of whether you have, quote-unquote, secured the airway. You can bag all the way to the hospital. That's totally fine. And so I think, speaking as a paramedic, that I would probably avoid intubating peds in most cases because I would not be confident in my skill to be able to do it, and I want to get them to the place that has all the tools and all the skills to do it correctly, because if I can oxygenate the patient, then the emergency's over. I can bag them all the way to the hospital, and there's enough people on scene that I don't have to worry about intubating them and then putting on a transport vent because I'm solo. Someone can hold the seal all the way there. We got plenty of hands. So I don't think there's a reason to necessarily jump to that.
I'd like to add another layer to this conversation real quick and add in the fact for those medical directors and people who look at this equipment in an ambulance, pediatric intubation comes with multiple blade sizes, both your Mac and your Millers, multiple tube sizes, having to choose the appropriate size and the appropriate depth. And with that, there's an extra cost and weight equipment storage in your rig.
Amen. You want to take the emergency medicine resident point of view about why you need to get a lot of practice?
Awesome. Thank you guys so much for participating in this.
Thank you. My pleasure.
Welcome.
EMSNation. I hope that really pushed you guys to learn more about the intubation of critically ill children in the pre-hospital sphere, which is obviously, as we know, a lower resource or limited resource environment. We'd love to hear your thoughts and opinions, so please tweet us at EMS_nation and let us know what your approach is to the advanced airway in children. Are there any nuances or techniques that your system deploys operationally? How often do you all train, and what does your training consist of when it comes to the advanced airway, specifically in children? And to what effect do you all use simulation? We'd love to hear more from you guys. Thank you once again for listening in. And we'd just like to throw out a shout out and message. We will be traveling to EMS Gathering coming up in Killarney, Ireland, as well as Smack Dub in Dublin, Ireland in the month of June, just a couple of weeks away. So if you are a listener to the EMSNation podcast, please stop us and say hello. This is Faizan Arshad wishing everyone a safe tour.
Hey friends, I'm going to take a brief moment to pause the show and bring you a word from our sponsors. No, not the sponsors you may traditionally think of, but rather sponsors that are aimed to help eliminate healthcare disparities. This is a very special project I'd like to announce during EMS Week for folks to trial. It comes at absolutely no cost and is ultimately designed to optimize your training experience and help translate into improved outcomes within your community in relation to out-of-hospital cardiac arrest. Recently, a group of colleagues of mine and I had the pleasure of coming together and reviewing the science and literature on feedback in CPR, and the data pretty much speaks for itself. Dr. Bobrow, the State EMS Medical Director of Arizona, has done tremendous work on this, and we now know that all the major defibrillator companies come with some sort of active CPR feedback. Nevertheless, we are acutely aware that once you know a single EMS system, you know a single EMS system, and budgetary constraints are real-world problems and challenges. Not everyone can afford the defibrillator component to their device. So what have we done is designed a watch app for the Apple Watch called Perfect CPR. Now, we should be very important to state this is designed for training purposes only, but nevertheless, once a provider opens up the app using the accelerometer and gyrometer built into the Apple Watch, you will be able to get direct feedback on your rate, depth of compression, as well as recoil. So please check this app out. It is available at $0 in the Apple Watch iTunes Store and is called Perfect CPR. Please also find us and follow us on Twitter at Perfect CPR. Again, we're beta testing for this, very excited to launch during EMS Week at a cost of $0 and would love your feedback. We can all do a part to help improve the health disparities within our country, and feedback